Welcome to the LACNet's podcast. I'm your host, Lisa Yen. I'm the LACNet's Director of Programs and Outreach, as well as a caregiver and advocate for my husband who is living with NET. In each podcast episode, we talk to a NET expert who answers your top 10 questions. This podcast is for educational purposes only and does not constitute medical advice. Please discuss your questions and concerns with your physician. I'm really excited to introduce our special guest for today, Dr. Maryam Lustberg. Dr. Lustberg is an American breast oncologist and the director of Breast Center at Smilow Cancer Hospital and the chief of breast medical oncology at Yale Cancer Center. She previously served as the medical director of Cancer Supportive Care Services at Ohio State's Comprehensive Care Cancer Center. She is the immediate past president of the Multinational Association of Supportive Care in Cancer and also the associate editor for the Journal of Cancer Survivorship. She is well-published, over 264 publications, and is often invited to speak nationally and internationally on this topic. And I saw that you're on the agenda for ESPO, the European Society of Medical Oncology, coming up in a couple months. And we're really excited and fortunate to have you join us today. One fun fact I'd like to share is that Dr. Lustberg is a single mom with a 10-year-old, and she's celebrating her son's birthday this weekend with a fun trip to New York City. Dr. Lustberg, welcome. And we'd like to invite you to share a little bit about how you got involved in this area, I guess as an oncologist and also specifically in this topic of supportive care.
Thank you so much, Lisa, for the introduction, and thank you to all the listeners for joining. So I started out in oncology fellowship, not quite knowing what survivorship care was, what supportive care was, but I was fortunate enough to be teamed up with a mentor who really was one of the pioneers in this area, Charlie Shapiro. And I think I learned a lot of those initial foundational information about the importance of taking care of the whole person as we treat their cancer. So I think that was my entry into this field. And I started doing studies with him in terms of, we know there are many side effects and toxicities from cancer itself, as well as many of our cancer treatments, regardless of the cancer type. I think certainly there are unique aspects to each cancer, but there's also a lot of commonalities as we talk about today. And there's so much we can do in terms of supporting patients, supporting families, supporting caregivers as they go through this experience that nobody signed up for. But certainly while they're going through it, there is so much we can do to try to make it better.
Making it better, that's really our hope and our goal, right? We want to have a better quality of life. And this area, what you do really resonates with us, with me personally, with us as a community. This topic came up because on our recent podcast recording with Dr. Pamela Kuntz on chemotherapy, many of our questions actually revolved around what's the side effects, what can patients do, because that's often how patients weigh their treatment decisions, right? They want to know what they're getting themselves into. And once they accept the treatment, that's really their focus. What do we do? How do we get through this? And then what do we have to worry about in the long run? Because the whole hope is to be able to live well. As you said, there's a lot of commonalities with different cancers in terms of this topic. So we really appreciate you sharing your expertise.
Thank you.
I guess let's get into the top 10 questions in this topic, if that's okay with you.
Sure.
Well, I guess the first question we can start with is, what is supportive care in cancer, or what is the terms that you use for this? I've seen in some of the writing, supportive oncology, survivorship. What are these terms and concepts, and how do they apply to the NET cancer community?
So just a warm hello to all the listeners in the NET community. So thrilled to connect with you. So yeah, to answer your first excellent question, I do think the terminology has been confusing. My suggestion to all of us would be that we don't get too focused on the terms themselves, but focus on the principle. But the way I would think about it is supportive care or supportive oncology. If you can envision a big umbrella that encompasses care of individuals and families and caregivers from day one of diagnosis throughout the entire continuum of cancer care, really to the end of life. So just think of it as this huge umbrella where, in addition to delivering cancer therapies, we're also addressing different needs that come up related to cancer symptoms, treatment toxicity. So within this umbrella, there are overlaps with other terminology that some of the listeners are familiar with. It might be palliative care, survivorship. All of these fall under this bigger umbrella of really what we all want to do is to support every patient from day one of diagnosis throughout their life. And we know there's physical symptoms, but there's emotional symptoms, spiritual symptoms. And so really being holistic in terms of how we think about it. So that's broadly what supportive care is.
Wow, holistic care and supporting us through the whole journey. That sounds perfect.
A question that keeps coming up is who is a cancer survivor? And I think there is a lot of broadness to each of these terms because more than anything, we want to be inclusive because we don't want to be exclusive to one group. So the NCI definition of a cancer survivor is really anybody diagnosed from day one of diagnosis, also to the end of life. So really these broad definitions, all they're trying to say is that our job as clinicians and researchers and this cancer community is to take care of patients in the most holistic way. And so whether some patients like to call themselves the cancer survivors, others don't like the term. So my suggestion would be that we don't get bogged down in terms, but really just think about what our goals are as a community.
I'm glad you said that because that term can be challenging in the neuroendocrine cancer community where you're not done.
Exactly. And I really do want to point out the term doesn't resonate with some folks. It doesn't mean that they're not, but really you get to define how you see yourself. And certainly I think to shout out what the limitations of previous survivorship research in the past was that a lot of the research focused exactly on the population that you're mentioning, Lisa, which is people who are done after 3 months. Well, certainly that does not apply to many of your listeners. So the idea is that there are many patients, many cancer survivors who will be on ongoing treatment for the rest of their life. And whether they identify with the term or not is less important than what are we doing as a community to support needs, whatever they may be.
So this is probably a new concept or shift in understanding of how people may have previously thought of it. And even in the past, historically, maybe some of the resources and clinics were only available to people who were done, quote unquote, done with their treatments. And so you're saying it can start with day one.
Yes. So, what we have heard loud and clear from patients, patient advocates, the patient community is that really, these needs don't just start after 6 months from having started treatment. Really, that initial time period when you're told you have a cancer diagnosis, the listeners can think about that time in their own life. Just the myriad of needs and emotions, both physical, so many things going on and swirling in your head. And I think it's important to acknowledge that as an oncology community, we have not always done the best job of supporting patients throughout these different phases of the cancer continuum. And to your excellent point, yes, there are a lot of survivorship clinics that in the past historically have focused on a very narrow group of patients. And we're really moving beyond that. The National Cancer Institute has really made it a priority to study diverse survivorship needs, and this has become a priority.
So again, things are evolving, and it's wonderful to see that.
It's not perfect yet. I do want to acknowledge your listeners who probably have had less than optimal experiences within many healthcare settings. I'm not trying to make it seem rosy. I think there is a lot more work to be done in this area in terms of how we support patients diagnosed with any type of cancer, but we recognize that at least we haven't done a good job and we're trying to remedy it.
So if we can start with day one, what is the first step? What's supportive oncology look like for patients?
I think foremost, certainly identifying a team that is supportive of your needs. And sometimes that means getting that second opinion and really finding the location that has the resources that you might need. Now, certainly that may not be as easy for certain areas of the country or due to insurance restrictions, but trying to find as best as you can a center that in addition to the cancer specialist, it's a team sport. So an oncologist by themselves cannot address all of your needs. So access to what we call psycho-oncology services, where we can look at ways to support cancer-related distress, which often peaks at the time of diagnosis. And each time you have to change your treatment. So the listeners can think about that. You can kind of cruise for a while and you have a certain level of stability, but anytime something has to be changed, where there might be a change in the cancer status, there's often a spike in cancer-related distress. What do I mean by distress? For the general population, people might say, is this depression? Is this anxiety? But it's more than that. Cancer-related distress is an actual emotional response to the stressors of the cancer diagnosis, cancer treatment. And it's a real thing. And it brings up a lot of triggers for patients. And I think it needs to be supported. And it may be that there is a specific social worker or a psychologist that is adept at listening. It could be very short counseling sessions or just feeling heard within your oncology team that these feelings are normal. Physical symptoms related to cancer and cancer treatment, we know that no matter what your diagnosis and what your cancer, moving more and being active and having those physical symptoms addressed through the care of oncology rehab specialists, these are the physical therapists and oncology occupational therapists, actually makes you tolerate your cancer treatment better. So again, if we wait just 6 months, 12 months, 2 years after starting with those services, we've sort of missed the ball. Whereas if we can start and integrate the care of the whole person from the beginning, the whole trajectory of the cancer could be different. Is this happening 100% of the time? No, unfortunately, but it's really the model of care that we're looking for.
That sounds amazing. Truly whole person care. So you mentioned so many things, many avenues we could explore a little bit more. Let's start first with some of the things that you were talking about, like adverse events. What are some common side effects or adverse events? And are there certain risk factors for them? Like, will all patients experience all potential side effects?
So I think it's important as the listeners may be on very many different treatments. So just as there are unique individuals listening in, I think you're on a whole host of different treatments. Some of them may not be chemotherapy-based. Some of them may be targeted therapy. Some of them may be very maintenance-based medication. So I think knowing what regimen you are and what it exactly is, I think is also one of the ways that you can empower yourself to also have these conversations with your oncology team and knowing what to look for. But in terms of the commonality across many of these, the number one symptom toxicity that is actually reported by patients of all cancer types is called cancer-related fatigue. The acronym is CRF, but it's very different than the fatigue of patients who do not have cancer, who climb a mountaintop. What I've learned from my patients over the years is that the fatigue is just more like your entire body actually feels the fatigue, and it can be a very overwhelming emotional thing that's coming in different degrees. So I would say that's probably the most common side effect, whether you're on chemotherapy or not, and it varies from patient to patient. So we can talk about that. And then there are very specific toxicities to chemotherapy that we can certainly talk about as well.
That really resonates. We hear this all the time in support groups. So what are some strategies to manage it?
So it's a very well-studied area. And what studies have shown is as much as all of us would dream of having a pill that we would take once in the morning, and it would take away our cancer-related fatigue. Unfortunately, that's not what the studies have shown. A number of stimulant medications have been studied, different medications have been studied to see, is there a certain vitamin we can take, or things like Ritalin and drugs like that. And what the studies have shown is that compared to not taking anything at all, the effect is modest, if even negative. But what has been shown to help the most actually is movement. So the more gentle movement, physical activity, exercise, that has been shown to have the most impressive effect on fatigue, which is counterintuitive because sometimes you're so tired you don't want to move. So the way I explain it to my patients is it's a balance. It's a balance of energy conservation where you rest when you need to, but also on a really bad day, if you can encourage your body and yourself to maybe do 5 to 10 minutes of gentle stretching and slow walking, that's actually what the evidence has shown to has the most profoundly positive effect on cancer-related fatigue. The second thing is to not always assume it's the cancer or the medication because there are other contributors to fatigue, so we don't want to have a super narrow lens. So a good oncology team, when you report your fatigue, also needs to look at common other things that would happen regardless of cancer. So we want to look at your blood counts. We want to look at your thyroid function. We want to look at certain blood work, screen for depression, screen for sleep issues, sleep apnea. most often those workup are negative and it ends up being cancer and cancer-related fatigue. But I also would encourage listeners to advocate for themselves, that we're not just making those quick assumptions.
Really good points and pearls here. You answered a multitude of questions about what can be done. And as you said, everyone wants to just take a quick pill. And movement. What is the minimum amount of movement that you would recommend?
I would tailor it to the individual. I think if you have never done any type of physical activity or exercise, definitely don't start out doing 2 hours a week or anything like that. It could be as little as 5 to 10 minutes. And if you really don't know how to start, this comes back to the supportive oncology services. If you can ask for a consultation with a physical therapist or oncology rehab specialist, they can devise a regimen that meets your physical and health needs. So I think sometimes we do this. We say, go do it. But really, this is a prescription. Just like I wouldn't tell you to just go pick up your prescription medication without explaining it and adjusting your dose. Really, the new thinking is that even as we advise patients about exercise and movement, we have to think of it as a very specific prescription. And ideally, if you really don't know how to get started, I think even a one-time consultation with an oncology rehab specialist can really clarify things and make sure that you're doing things in the safest way. But to further answer your question, I think a lot of studies have shown that if we can work up to about 150 minutes a week, a combination of both aerobic as well as resistance training, that seems to be where we get the most benefit. But it doesn't mean that you don't get benefit from less.
That's really interesting. There are people in our community who are big runners or swimmers and they run marathons. Does that mean that if you do more, it actually may be protective for side effects of treatments?
Yeah, so I think it's so wonderful that there are people who can do more and are doing more, and there are a myriad of health benefits. But in terms of toxicity management and things like that, it seems that we can get away with about 150 to 200 minutes. And if we can get most of our population to that level, I think the whole health of this country would be quite different. So no, this is not to in any way suggest to others who are doing more to do less. It's wonderful. There's so much that we're still learning about the dose and intensity of exercise. But I think for the average person, working toward that 150 to 200 minutes a week seems to be that magic number.
I love that you said it's a prescription too, and there's a tailored plan for the individual.
Yeah.
So what other common side effects do you see with treatments?
So I know with many of the regimens that your community uses, diarrhea is a side effect that can really affect all aspects of our life. It's a huge quality of life affector. And we can see it certainly not just with chemotherapy, but with a lot of the other therapies, with our targeted therapies. So I do want to maybe spend a few minutes talking about diarrhea. And what I've noticed from a lot of patients is that they tend to not complain enough about it or just kind of want to write it out. And I think in general, I hope I can encourage listeners to know that they don't have to suffer with diarrhea, that it's not something that we expect them to just manage on their own. So there are many medications that can be used to manage diarrhea. It can start at the simplest with over-the-counter medications like loperamide, but then there's multiple steps we can take to manage these complex diarrheas. There may be diet impact, and I think that varies from patient to patient. And so listening to your body to see if certain foods, you may be more sensitive to dairy or you may not be. So there's no one prescription for diet and diarrhea, but just seeing those patterns, I think would be helpful. And then 3, I think there's some interesting research in terms of the role of probiotics and gut health and diarrhea. And I think we're still learning about this. So I don't have a defined prescription for you for that, but I definitely don't want to dismiss the huge role of gut health and how it interacts with diarrhea and toxicity. There's a lot of great research going on in this area. So I think some patients can discuss with their teams the safety of potential probiotic supplementation before taking it. But these are all the things that we're researching, and lots of new drugs that manage diarrhea are actively being researched.
I'm glad you mentioned that because, as you said, this is a common area and many questions come up regularly about what can be done about it and proactively too. What about other GI side effects? I mean, nausea comes up frequently.
Yeah.
Also, other things like mouth sores. What can be done about those things?
So nausea is also quite common with a range of our therapies. One thing I want to say that sometimes people have a preconceived notion about what nausea may feel like and dismiss other symptoms that are nausea mimics. For example, sometimes just a vague abdominal discomfort may be your nausea counterpart. So just keeping a broader differential in your mind of what nausea feels like. Sometimes when patients just feel like kind of queasy in their stomach, but they're not quite connecting the dots, that this may respond to their as needed nausea medications. So nausea is centrally mediated. So there are actual receptors in our guts and GI tract that communicate with our brain and release certain substances that actually promote nausea. So we have drugs that specifically block these pathways. If you're on chemotherapy, depending on the type of chemotherapy that you are receiving, on the day of chemotherapy, you may get pre-medications to help prevent the nausea from happening. For certain medications, we want to actually prevent the onset of nausea, and these may include medications such as steroids and other 5-HT3. These are all receptors that we're trying to block to modulate this brain and body connection that's happening. But then there's nausea that's more of a delayed nausea that can happen several days after administration of chemotherapy. And then these are where your as needed medications come in. So the one drug that I really do want to highlight for patients who maybe have tried everything and they're like, yeah, my nausea just doesn't quite respond to the traditional medications, is a repurposed drug. This is a common thing that happens in cancer care and supportive care, is a drug that was used for other indications. Olanzapine previously was an agent used for different mood disorders, but then it was shown based on this biochemistry of the brain and these dopamine pathways that it can actually be one of our most powerful anti-nausea medications. So for patients who are really struggling, just a low dose olanzapine at night can both help with sleep and be quite a powerful medication for management of nausea, and it can also be an appetite stimulant. So lots of data are emerging about the use of olanzapine. It can be started at a super low dose of even 2.5 milligrams. The side effect is sleepiness. That's why you want to take it at night. So I think lots of options for nausea management, but what I also see is that sometimes patients also underreport their nausea symptoms because they're afraid that their cancer regimen might be modified and they're afraid of their cancer regimen being modified. And I would just encourage them to know that we don't always end up reducing the dose of the medication, and there are things that we can do to really manage nausea. So don't be afraid to report those symptoms. And then similar to fatigue, looking for other contributors. Yes, it's most likely our cancer medication, but we want to also keep a broad differential, making sure that, for example, it's not because your stomach lining is irritated or you're not developing gastritis. Sometimes simply adding an acid blocker, because some of the chemos and the steroids can be irritating. Simply adding an acid blocker medication like a proton pump inhibitor can actually calm the acid production, and just a simple change like that can help with nausea. Identifying certain food triggers can help manage nausea. So it really needs to be that personalized approach.
Wow, so many helpful pearls here, lots of tips and tricks. I know one thing my husband's oncologist said was, we have come a long way in the past several years with the management of nausea.
Yes.
So it's not like it was in the past. And what maybe media, movies and TV shows have shown. So there's a lot that can be done. It's not just one or two medications.
So important. Very, very true.
And can they be used in combination? So you mentioned those medications are commonly used. A lot of people in our community might be prescribed to take as needed. And then you're mentioning olanzapine at night. Can you take multiple medications for nausea?
Obviously, review your med list with your oncology team, and obviously they're the ones prescribing it. But yes, so because they're hitting different receptors and different pathways, they can absolutely be combined, and they may be hitting different biological mechanisms of that nausea pathway. But I think first and foremost, the takeaway here is understanding acute nausea and delayed nausea and being able to describe that to your team would be important. If it's more of an acute nausea, then we can optimize your day of chemo medications so that you're not struggling at home that day or the day after. If it's more of a delayed nausea, then we can optimize some of your as-needed medications or even prolong a few days of the steroids that you take at home, do a longer taper. There's so much we can do. Some patients don't like to take extra medications, and I definitely respect that. There are limited data for acupuncture. So if there is access to acupuncture for some of the listeners, there are actually a decent amount of data showing that acupuncture and focusing on these nausea acupoints can also be one strategy.
Okay, that's helpful to know. So what other common side effects come up?
Yeah, so you mentioned mouth sores, and I know certain targeted therapy that the community uses, including everolimus, Afinitor, and others, can be associated with mouth sores. And so this is an evolving area as well of research. But what we do know is that steroid mouth rinses, dexamethasone mouth rinses, particularly in the first few months of everolimus use, have been shown to actually significantly reduce significant incidence of stomatitis and mouth sores. It's not the greatest tasting mouth rinse, so I do want to say that sometimes patients don't like to use it, but simply rinsing your mouth a few times a day. The study was done with 4 times a day. 4 times a day can be hard to do, but even a few times a day of this dexamethasone mouth rinse has been shown to really help with the everolimus mTOR associated stomatitis. Sometimes there's a prescription coverage issue and things like that. If that's not available, certainly using moisturizing mouth rinses that are available over the counter or baking soda with water mixed in can be helpful. For patients who are more on the traditional chemo agents and are developing mouth sores, we do have some limited data that simply sucking on ice during treatment administration, cooling the mouth. You can think of a popsicle if it's available, or simply just ice that's routinely available in infusion centers. Cooling this oral mucosa can be helpful potentially. We don't have phase 3 data on it, but we do have some limited data and it's little harm. So sometimes I do have my patients try that. And then if you do have mouth sores, there are actually pain medications, medicated mouth rinses that have pain medications included that can be helpful. A little bit of data on doxepine mouth rinse. And also when you're in pain, I think not being afraid if it's quite painful to actually take opioid pain medications if you're in a lot of pain. In general, I think with many of our modern regimens and just knowing what type of regimens that this population uses, I think the very, very severe mouth sores that we see maybe in the leukemic population getting transplant, those are not what we're seeing here. But certainly it can be uncomfortable and we want to adopt some of these supportive care strategies to manage that. If you're feeling the soreness, avoiding citrusy, acidy foods can also help it feel less painful.
Good point. It's good to know that there's lots of options, not just the steroid rinse. So I know one thing that comes up with chemotherapy, and my husband being a musician, this is something that he's concerned about too, is peripheral neuropathy. What is peripheral neuropathy and when do you see it and what can be done?
So it can be seen with a number of agents, including oxaliplatinum, which is used in certain regimens within NETs. It can be seen with taxanes. It can be seen with carboplatinum. So these are the carboetopicide regimen that's used in poorly differentiated NETs can be associated with neuropathy. So what's happening is that these agents are damaging the nerve endings in the hands and the feet. And it's called peripheral neuropathy, but what's really intriguing about it is that also connects with our brain. So the idea, again, of holistic care, we're used to thinking of our brain and body being very distinct, but really even peripheral neuropathy, there's actual communication to the brain through these nerve endings that then communicate with larger nerve endings that then communicate to our brain. So we actually see changes within the brain when this peripheral neuropathy condition can happen. And it could feel like numbness, but it can also feel like pain. And it may actually also impact balance, which is not talked about enough. So if you're feeling like you're not able to walk as steady as before, that may in itself be a manifestation of neuropathy. So it's an off-target effect of these traditional chemo agents where these nerve endings become damaged, and how they get damaged. There's a lot of research into this area, but there's a component of inflammation and direct neuronal damage. These neurons, which are the building blocks of our nerves, actually get damaged from the chemotherapy. And it can impact us in a number of ways. One, it does not feel good. It can be quite impactful on quality of life, but in its most severe forms, it may lead your oncologist to have to reduce the dose of the medication, which may or may not also impact the efficacy of the treatment. So it's something that we're trying to learn more about and try to manage. Many people might approach you with their prevention cocktail, take this vitamin or take that medication to prevent neuropathy. But really, when you actually appraise the evidence related to prevention of neuropathy, no trial has been positive to date. Perhaps the most promising thing is related to cryocompression, which is cooling the extremities, and the phase 3 study for that is currently ongoing. So officially, we don't have a preventative strategy for neuropathy, but what has been shown maybe to be helpful is maybe cooling. Exercise has been shown to be helpful in small studies. For the more active you are, it's releasing these vasoactive substances that may protect the nerve endings from damage. Some limited data with acupuncture as well for prevention. And then dose modification and dose reductions. I think if you're older or diabetic, where these nerve endings are extra friable and prone to damage, I think potentially starting at a smaller dose to begin with, just to see how much your nerve endings can tolerate, would be important. For treatment of neuropathy, the one agent that has been shown to be most helpful is duloxetine or Cymbalta. And it was shown to be particularly helpful for oxaliplatin, which I know this community may use as part of the FOLFOX regimen. So duloxetine can be used. Data with some of our neuropathic agents, such as gabapentin, are much more limited, but they are used sometimes. I do refer my patients to acupuncture, but the phase 3 study for acupuncture is currently ongoing.
Yeah, you mentioned lots of things, and we hope to get a few more answers in the future.
What does not work is there were older studies with calcium and magnesium supplementation for oxaliplatin neuropathy, and they were negative. So if people are trying to sell to patients, there are these infusional practices that want to sell magnesium infusions or calcium infusions. Those have not been shown to be helpful. And B12 complexes, you may hear about, take some vitamin B, and it actually has not been shown to be helpful in well-controlled randomized studies. So the recommendations from the American Society of Clinical Oncology is to not use these agents for prevention or treatment of neuropathy.
You mentioned the cryotherapy that's in the ongoing clinical trials. What about those cold gloves that sometimes you see?
Yeah, so I think I do talk to my patients about these, saying that our data are now from phase 2 studies, which are typically smaller studies. The definitive phase 3 data we're awaiting. But I think if patients do really want to use them, it's something that they can absolutely do. The risk is a small risk of frostbite that can happen with these. So if something is hurting while you're wearing these gloves, don't simply bear it during the infusion. Take off the gloves and see what's happening. If there's color change and things like that, you want to watch out for. The community here using oxaliplatin, we know that it can cause that acute cold vasospasm that we sometimes see. The data for cooling are a little bit more limited with oxaliplatin. A lot of our data are with other types of chemo, such as taxane. So I do want the patient listeners to know that we're still learning about this and it's not a standard of care right now.
Thanks for that. Let's shift to another area that often is neglected or not talked about, and that's about fertility and sexual health. What would you like patients to understand that they can be supported in this area?
Absolutely. And I think as an oncology community, I think this is an area where we have not done the best job, but greater recognition has been achieved in most recent years that we need to do a better job. So many of our agents, both targeted therapies and traditional chemotherapies, may impact both ovarian reserve in females or sperm production in males. We know most about traditional chemotherapy and what the risk is. We know less about these targeted therapies, but I think some data that many of them could also affect fertility. So I think taking a pause when you have that cancer diagnosis and there's so much going on and asking this question, even if your oncologist may be not bringing it up, hopefully they are. And if completing your family or starting a family is a personal goal, we want to know about that. And depending on your future fertility goals and future family planning goals, I think the safest thing, because we don't fully understand what happens to fertility with some of these drugs, would be to see a fertility specialist, and for males, potentially banking sperm, and for females, doing some type of egg harvest. If they're currently partnered, they can also have a discussion about fertilizing the eggs and preserving them for the future. So that tends to be the most proactive way of managing this. And then if it does not impact fertility, then you still have other options, such as doing it the way you would have done it prior to the cancer diagnosis. But having this backup is something that we at least have a discussion with our patients. So the drawback is cost, because fertility preservation methodologies are not routinely covered by insurance in many states. Some states have coverage, your insurance may have coverage, so it's all over the place. So that's been the main limitation. And this is maybe less applicable to this population, but I know with very rapidly, poorly differentiated NUTS tumors where you may need to start chemotherapy very, very quickly, where there might be a much narrower window where you have to do these things. Typically, they take a few weeks, less in males. So those are some of the considerations. But I think not being afraid to have these conversations, and I think they should absolutely be brought up for those who are 40 or less, for sure. And then in terms of sexuality, we know that cancer and cancer treatments can be absolutely impactful on libido and sexual function, and it can impact interpersonal relationships. So lots of help available in this area. But what we do is patients don't like to bring it up sometimes. Oncologists don't often bring it up. And so there's this space that's not discussed. And I think the main takeaway is not being afraid to bring it up. And it may be not your oncologist expertise area, but hopefully then they can refer you to some type of a specialist within the supportive oncology umbrella. This could be a sexual health expert, a psychologist, or a urologist, or a gynecologist who can help manage the side effects if it's more of a side effects problem, or if it's related to desire or related to interpersonal communication. There are actually lots of strategies that we can use. But I think the biggest thing is that patients don't know that they could ask an oncologist.
Yeah, talking about it is the most important thing. And then going back to what you were talking about with distress, what can be done about distress and anxiety and depression?
So I want to validate it, first of all. And, we are such a go, go, go culture, but being able to sit with a patient and taking a moment and hearing that concern, giving that safe space for verbalization of distress itself can do wonders. If it's persisting, I think some patients enjoy support groups. Some use these peer online groups, which can be helpful for some, feeling that they're not alone and that these feelings are normal. So a combination of one-on-one counseling or using support groups or peer support type mechanisms can be helpful. For persistent feelings that feel like depressive mood or anxiety, we actually do have very wonderful medications in the form of serotonin uptake inhibitors as well as others. The way I describe it to my patients is back to the brain. We have a lot of neurotransmitters and hormones in our brain that actually get depleted in times of stress and due to cancer treatment. And it's hard to feel good and it's hard to feel like yourself if your normal levels of neurotransmitters have been depleted because you've been going through treatment after treatment, coming to these appointments. It can be a lot. And so these medications, the way I present it to my patients, are trying to simply normalize those levels back to the levels that you normally were living in. And so certainly there are lots of options, and it can be prescribed by your oncologist. Many of us prescribe these. It can be prescribed by your primary care. And then in select cases, certainly a psychiatrist or a psych APPs can certainly prescribe these as well. But not being afraid of treating mental health just like any other medical condition would be my message here, and that there is lots of help. And generally what helps the most is a combination of talking and medications.
You're a wealth of information, and I think we could keep talking for hours, but we'll just end with this. Whether someone's in the beginning of their journey and feeling very overwhelmed or have been living with this for many years, as you know, it's such a roller coaster of uncertainty. So what would you like to leave the community with? What would you most like to share with them?
There's a lot of information out there, and I think the fact that they're listening to this podcast and really forming this community, I think is a wonderful step. Because it can be hard to make sense of, yes, we have web-based sources, but it's hard to curate all these fragments of information. So I would say build your community, be a part of this greater community, because there's a lot that we can sort out for you and just package for you so that then you can choose the different options that are right for you. Not being afraid to voice your concerns. I think, as I mentioned earlier, I fully acknowledge that healthcare systems don't always function optimally, but one of the ways that I do think we have recognized what our shortcomings are is that patients have spoken up. They have told us what they need. So continuing to advocate for yourself, I think, is important. And certainly it's not easy, and there's no way I can fully understand everything that all of you are going through, and I don't pretend to, but I just, in communicating with different patients and families over 2 decades, I know this can be hard stuff, but work with us to try to make it better.
Yeah, it takes a team. Finding and using our voice, finding our community. Thank you so much for being part of the community, for joining us today, for sharing all of this amazing information. And we really are grateful for all you're doing in this area. And we look forward to your continued work and all you're doing.
Thank you so much, Lisa.
Thanks for listening to the LACNETS podcast. Go to our website, lacnets.org/podcast for episode transcripts and resources. We want to thank our podcast supporters, Novartis, Ipsen, ITM, Crinetics, Curium, Exelixis, and Boehringer Ingelheim. For more information about neuroendocrine cancer, go to www.lacnets.org. LACNETS depends on donations to bring you programs such as this podcast. Please consider making a donation at lacnets.org/donate.